I call upon Dr. Marwan Obaid. Dr. Marwan is very well known to us. He's a staff specialist endocrinologist at the Diabetic Center, Bankstown Hospital, conjoint lecturer at University of New South Wales, and his private practice at Inner West Specialist Center, Burwood.
Okay, thank you, Adnan. So I've got a lot more slides than I have time to discuss, but my job is to give you a message at the end of the session. So just some hands up, who's a general practitioner in the audience? Okay, great, so there's quite a few of you. So look, type 2 diabetes has come a long way in the last 10, 15 years, but particularly in the last 5 years. There's been a proliferation of treatments to control glucose and also injectable therapies, different insulins, but especially with the tablet therapies where as general practitioners you're dealing with tablet therapies every day. And so there's been such a proliferation of therapies, and trying to understand where they fit in after metformin is challenging, and I can understand that. But what we are excited about in type 2 diabetes is that we don't just have new medications that can control glucose, we have medications that can offer patients more than just glucose lowering, and that is reducing the risk of cardiovascular disease, heart failure and chronic kidney disease. Because people with diabetes, they don't die from their glucose level, they die from cardiovascular disease. So, and I apologise if I rush at some points, but there's been a new guideline regarding the management of type 2 diabetes that was published and presented late last year, and it looks quite confusing when you look at it, and it's there on the right hand side, but I'm going to try and simplify it for you. So type 2 diabetes is a complex disease, but if you try and keep things simple, and the guideline attempts, it looks confusing when you look at the actual guideline, and it's the ADA, the American and European guidelines. They're going to be adapted into the Australian Diabetes Society guidelines, just hasn't happened yet. But I want to try and keep it simple and send you home with a simple message at the end of the day. And some of you are probably already putting into practice this message anyway, based on all the cardiovascular outcome trials in type 2 diabetes, particularly in the last 5 years, that have shown some rather stunning results, surprising at times, but very beneficial for our patients. So on the left here, first-line therapy is still lifestyle and metformin. Metformin has been around for a long time, it's safe, it's cheap, it's well tolerated by most people, and it's weight neutral. So that's our first-line therapy. Lifestyle is important. We've got to always reaffirm, re-explain to patients the importance of being careful with diet and exercising to their limits. But not all of our patients with type 2 diabetes are able to get an HbA1c target of 7% or less on metformin and diet and exercise alone, as you know in general practice. So when the HbA1c is above target, what's next? Now, previous sets of guidelines have focused on the various therapies and their side effect profiles and what may be, and their hypoglycemic risk as to what may be the next best step depending on what the patient can tolerate. But now our guidelines have changed. And they've changed because the first consideration, as you can see here on the slide on the right hand side, after lifestyle and metformin, is the first consideration is for you as a physician to determine whether the patient has atherosclerotic cardiovascular disease. Okay? So atherosclerotic cardiovascular disease could be the history of a coronary artery disease event such as acute myocardial infarction or a stroke, or peripheral vascular disease, or even just somebody that has coronary artery stenosis on a CT scan, or unstable angina, or positive exercise stress test, or a history of heart failure. So that's the first thing you need to do. When you have that patient in front of you, and it may not be just the patient who's on metformin and lifestyle, it may be someone you've been managing for years, and if that patient has a history of atherosclerotic cardiovascular disease, you need to stop and rethink what treatment they're taking and consider them for one of the agents with proven cardiovascular disease benefit. So one of the classes of drugs, one of the agents from those classes that we know not only lowers glucose, but separate to the glucose lowering, gives that patient a reduction in cardiovascular disease outcome and chronic kidney disease as well. And so patients with type 2 diabetes in part a very large financial cost in terms of cardiovascular disease. And you can see on this slide the risk of heart disease or stroke is higher, risk of mortality, cardiovascular disease causes 2 in 3 of all deaths for people with type 2 diabetes, and it reduces life expectancy. So people with diabetes don't die from their glucose. Yes, they develop acute hyperglycemic complications, as Dr. Aurora just explained, or hypoglycemic complications, which can, unfortunately, but we don't see very much of these days, cause them to die, but most people with diabetes are dying because of cardiovascular disease. So when we manage someone with type 2 diabetes, yes, it's really important to control their glucose, but it's also important to reduce their risk of cardiovascular disease. And so yes, it's important to choose a drug which reduces that risk, but don't forget also about controlling their blood pressure, lipids, smoking cessation, weight loss, all the other non-glucose cardiovascular disease risk factors. So I'm going to give you a case of a patient, and so Jim, 63, type 2, history of hypertension, coronary artery disease, diagnosed following an exercise stress test. He's on an ACE inhibitor, a nitrate, a statin, and aspirin. He was first diagnosed 5 years ago. Let's say he was diagnosed before we had SGLT2 inhibitors. The SGLT2 inhibitors have been around since about 2014/15, and so he was on metformin, his HbA1c was above 7%, and he's overweight. So what did you add on after metformin? A DPP-4 inhibitor, such as sitagliptin, completely appropriate, pre-2014, before we had SGLT2 inhibitors, because that was probably the next best step, because you're looking to choose something that's going to control his glucose, but not going to cause him to gain weight. So you might have also considered a sulfonylurea, but a sulfonylurea you might have avoided because it causes hypoglycemia and weight gain in some patients. His BMI is 31, eGFR was mildly decreased, he was admitted to hospital sometime down the track, let's say months later, with chest pain determined to be due to acute myocardial infarction. He died after a fatal cardiac event. So this is an unfortunate outcome, but people like Jim are not uncommon in Australia. An analysis from the Baker Heart and Diabetes Institute in Melbourne showed that 7,000 Australians with type 2 diabetes and cardiovascular disease die every year. So this is an unfortunate outcome, and so what we might be able to do now, based on the evidence that we have from cardiovascular outcome trials, and they were done to check safety. So a lot of the trials that have shown us the very stunning, sometimes surprising results were actually performed because there were some risk signals with some drugs. If we go back 15 years to say 2003, do you remember rosiglitazone and Avandia? And there was another drug as well, which didn't make it to market, which looked amazing in terms of their glucose lowering, but risk signals emerged. And so as a result of that, in 2008, the FDA in the US mandated that all clinical trials with type 2 diabetes drugs needed to have long safety trials to look at their safety in terms of cardiovascular disease. So I've just told you that we need to reduce the risk of cardiovascular disease in patients with type 2 diabetes, because that's what they're dying from. So we need to also be careful we have drugs that are safe in the first instance, but because those trials were done for safety and they were long trials, what they showed was a benefit. And the EMPA-REG trial with empagliflozin was the first one, and that was in 2015. Excuse me. The EMPA-REG outcome trial established cardiovascular. So the patients in the EMPA-REG trial had established cardiovascular disease. Excuse me. These patients in this trial, it was quite a large trial, 7,000 patients. They all had a history of either coronary artery disease, peripheral vascular disease, prior myocardial infarction, or stroke. About three quarters of them had coronary artery disease, and important to note that about 1/3 of them didn't have a heart attack or stroke before. They just had abnormalities on coronary CT or positive stress tests and, say, a single artery that was stenosed. So was adding a DPP-4 inhibitor the best option for type 2 diabetes in Jim's case? Well, at the time it probably was, but it isn't now. So if you see someone like Jim who's got type 2 diabetes and has a history of coronary artery disease, and his HbA1c is above 7% and he's on metformin only, the next best step is not a DPP-4 inhibitor. The next best step is an SGLT2 inhibitor or a GLP-1 receptor agonist, but in most cases our patients are going to be interested in exhausting tablet therapies. So what about DPP-4 inhibitors? Are they safe? Well, they're safe. You can see on the left-hand side that 4 large trials involving DPP-4 inhibitors that you've all used, so saxagliptin, alogliptin, and particularly the bottom two, sitagliptin and linagliptin. These are all DPP-4 inhibitors as GPs you've prescribed, and we still prescribe. I still use them, but they're not second-line therapy after metformin in most patients. Not everyone, but most patients, especially patients with a cardiovascular disease history or have multiple risk factors that are at risk, and that puts that patient at risk of a cardiovascular disease event. So they're safe in terms of that they don't increase cardiovascular disease on the left-hand side. On the right-hand side, if you look at the top right, the two trials at the top, there was a signal without statistical significance of a risk of increased hospitalization due to heart failure with saxagliptin and alogliptin, but sitagliptin and linagliptin were safe in terms of heart failure. So they're completely safe drugs, and they're quite benign drugs. These drugs don't cause a lot of adverse effects. Most of you have experienced using DPP-4 inhibitors for probably 10 years now. They've been around since 2008 or 9, and you probably use them with a lot of success in controlling glucose, and patients usually tolerate them pretty well. So, what about the EMPA-REG trial? I've just told you that empagliflozin is an SGLT2 inhibitor. I'm not going to go into the mechanism of how it works, we haven't got enough time, but in the EMPA-REG trial, there was quite an impressive and stunning result in terms of the reduction in this slide, cardiovascular death. There was also a reduction in hospitalization to heart failure, and there was also a reduction in all-cause mortality. So empagliflozin in the EMPA-REG trial versus placebo in patients with HbA1cs above 7%, in patients who had very good treatment. They were 80% of them were on ACE inhibitors, statins, aspirin, and they were well treated in terms of their glucose, except their HbA1c was above target still, and the HbA1c came down in the trial, but more than the HbA1c lowering effect, what was impressive was the early and sustained response with respect to reduction in cardiovascular death. So this was quite an impressive result, and this was the first of a number of trials in the SGLT2 inhibitor class, and also GLP-1 receptor agonists, which we won't go into, which changed guidelines. And so essentially now, after metformin, if your patient has a history of cardiovascular disease or heart failure or chronic kidney disease or has multiple risk factors and there's a concern they're going to develop cardiovascular disease, the next best step after metformin is an SGLT2 inhibitor or GLP-1 receptor agonist, and in particular empagliflozin, because it has proven cardiovascular disease benefit. So let's look at the number of patients needed to treat to save one life before statins. So this is the 4S trial looking at simvastatin. 30 patients needed to treat one life. This is looking at ACE inhibitors, 56 patients over 5 years to save one life with ramipril. And look down the bottom there, less than 30% of the patients were on a statin. Whereas in the EMPA-REG trial, where there's a large proportion of patients that are well treated with drugs that lower cardiovascular disease risk, on top of that, 39 patients needed to treat in 3 years to save one life, and this is type 2 diabetes patients with established cardiovascular disease. So very impressive result. So what about other SGLT2 inhibitors? So dapagliflozin was studied in the DECLARE trial, and on top left, first of all, is empagliflozin. You can see there's a reduction in cardiovascular disease, which I've just told you about. The same wasn't showed for dapagliflozin in the DECLARE study with respect to cardiovascular disease, but it did reduce the risk of heart failure. There is a thought that the patients in the DECLARE trial, dapagliflozin trial, they didn't have the same cardiovascular risk as the patients in the EMPA-REG trial. But certainly there appears to be a very profound reduction in cardiovascular disease death and events with empagliflozin. Heart failure and chronic kidney disease prevention is probably more of a class effect. So I've just said to you that the first consideration is whether the patient has cardiovascular disease. Well, if the patient doesn't have a history of cardiovascular disease, step 3 should be considering whether the patient has a history of heart failure or chronic kidney disease. Okay, so chronic kidney disease, microalbuminuria that's persistent, and or an EGFR of less than 60, chronic kidney disease. If your patient has chronic kidney disease and type 2 diabetes, and your patient doesn't have a history of atherosclerotic cardiovascular disease, or your patient has a history of heart failure, that's the next thing you need to determine, because they are compelling indications to add an SGLT2 inhibitor next line, whether it's after metformin or if the patient's already on metformin and a DPP-4 inhibitor, or metformin and a sulfonylurea. That's a compelling indication, because we now, in 2019, have very good evidence to show that adding these drugs with proven cardiovascular disease benefit not only lower glucose, that extra 0.5 to 1% or more, and help the patients lose weight, but they reduce their risk of heart failure and also chronic kidney disease progression. And these are problems that are common in patients with type 2 diabetes, as is shown on the right-hand side of this slide. People with type 2 diabetes do have a higher incidence of developing heart failure. Interesting point is that in the patients in the EMPA-REG trial, only 10% had heart failure at baseline, and the patients there was still a reduction in hospitalisation due to heart failure. So not everybody declares themselves with heart failure with type 2 diabetes. It is a problem that is probably identified, underappreciated, but patients with type 2 diabetes do develop heart failure and do end up in hospital with heart failure. So we can give them a drug that reduces that risk, and it's certainly a class effect. The DECLARE trial showed also in patients with and without cardiovascular disease there was a reduction in hospitalisation due to heart failure over the course of the 4 or 5 years of that study. Okay, so that's the slide from the EMPA-REG trial showing the event rates decreasing with empagliflozin in the blue, the light blue versus the dark blue, and again it was an early response that was sustained over the course of the trial. And the earliness of the response, you see the curves separate early, suggests that it's not due to atherosclerosis, that it's due to a hemodynamic effect. It's due to another effect, not due to atherosclerosis, the classic way in which you prevent cardiovascular disease when you give someone an ACE inhibitor or a statin. 4 minutes left. If the HbA1c is above target, as I've just mentioned to you, and the patient had atherosclerotic cardiovascular disease or heart failure or history of chronic kidney disease, these are compelling indications to add an SGLT2 inhibitor. And in terms of renal function, this is often a question I get. There's some concern about the effect on renal function of using an SGLT2 inhibitor, and the effect of an SGLT2 inhibitor on renal function is that in the first few months there is a decline in the eGFR, but that's because of the way the drug works at the level of the nephron, which I won't be able to go into detail, but it usually, as you can see, it drops but then it picks up, but over the course of years there's actually a protection benefit. And it's been clearly shown now in a number of trials that the drug doesn't cause a worsening in renal function. On the opposite, it actually shows a protection of kidney function over time. That's been clearly shown across all the drugs in the class. So this is a summary slide of the HbA1c lowering effect, weight loss effect, blood pressure lowering as well is something that we see with SGLT2 inhibitors. You've all seen that. Prevention of death and hospitalisation due to heart failure. Now, what I want to talk about before I get... Okay, so we'll finish up on this point, and
you have 2 minutes.
2 minutes, yep, I've got my own timer here as well. So urinary tract infection, there was no increase in the overall rate of UTI, complicated UTI or pyelonephritis with Jardiance empagliflozin versus placebo. But if somebody has a history of recurrent UTIs or a history of urosepsis, I think you'd need to be cautious about using this drug. Now finally, not on this slide, this is increasing rate of genital tract infections. This is something that it happens, 3 to 4% of patients, but is usually simply treated. Now, in terms of SGLT2 inhibition and diabetic ketoacidosis, I've already mentioned in commentary to the previous presentation that it is something that we need to be wary of. Quite simply, I tell my patients this. I say, if you become unwell, if you develop a fever, if you develop an illness that causes nausea or vomiting or gastrointestinal losses, stop taking your drug and restart it once you've seen your doctor and you're better. You're back to eating again and you're feeling like your normal self. Okay? You shouldn't go on to the starvation diets. Be very careful about following the the diets I'm referring to, the diets where there's a prolonged period of starvation or fasting if they're on an SGLT2 inhibitor. And they should maintain carbohydrate intake. Doesn't mean they need to maintain high carbohydrate intake. You need to maintain a balanced diet where you're having carbs with your meals, but you're not having excessive carbs that cause hyperglycemia, but you're not omitting carbohydrates altogether. And patients who are on insulin, who we give SGLT2 inhibitors to, be very careful about winding back their insulin dose. If they're going to reduce their insulin dose because the SGLT2 inhibitor is working and lowering glucose, reduce the insulin dose slowly under the supervision of a GP. If you take the appropriate measures in advising and educating your patients to take an SGLT2 inhibitor, you will avoid most cases of euglycemic DKA. The cases that I've seen at Bankstown, where I also work, and I've seen probably about 4 or 5 patients now in the last year or two, they all were unwell. They were patients that were unwell in terms of they developed an intercurrent illness. They all had some intercurrent illness that caused them to tip over, or they were starving, or they were following. There was one particular patient that dropped his insulin and had following a starvation diet. And one final point before I finish up is that in your patients who are about to have a procedure, stop it for 3 days. I think most of you have received that message, but they need to stop their SGLT2 inhibitor for 72 hours beforehand based on the half-life of the drug. So I think I'll finish up there.